Year-old child, Tufel, who's brought by and informed by mother with inability to walk and frequent falls while walking, is the chief complaint. I would like to start with the birth history for this patient as it is significant for this case. Patient was a full-term normal vaginal delivery with a birth weight of 3 kilos. But post delivery, patient had to be kept under for NICU stay due to as patient had weak cry and there was entangling of umbilical cord around the neck with meconium aspiration, as told by the mother. Patient also had seizures during his stay in the NICU, and he has been on medication for the same till 2 years of age, after which medication was stopped as seizures were supposedly controlled. Parent also notices that patient was walking with support at age of 2 years, and during and speech development of patient also appears to be hampered as he is able to speak only single syllable words. Patient is able to carry out his day-to-day activities, walks with support, is not able to run, and he has history of excessive drooling of saliva, for which he is on medication and has reduced over the past 7 years.
So in history, there are 2-3 points main which I would be interested in knowing in such a case of developmental delay. One is the perinatal history, which I think you have covered, but most importantly, I would like to know what was the timing of achievement of various motor milestones. So if you could come to that.
Sir, patient was able to walk with support.
Walking comes much later. Which are the earlier milestones that a child achieves?
Sir, he was crawling at the age of 15 months.
Start with head holding, sitting without support, sitting with support, rolling, standing, walking.
Patient was able to, head control was not achieved till the age of 1 year. He was able to sit with support at the age of 1.5 years, could not sit without support till around 2 years. Was walking with support at age of 2 years. Currently, patient is he has not been able to run or perform the vigorous exercise as reported by parent. Patient also needed occasionally needs support to while sitting for a long period of time. Patient is also not having ability to stand for a long period of time, and as parent reports, he has frequent falls while walking. But none of them have been significant to cause any fracture or any hospitalization for the same. Post the age of 2 years,
okay, you should also know, I mean, due to shortage of time, we will not cover all that. These are theoretical aspects, but you should also know the normal timing of achievement of each of the motor milestones to determine, whether they were delayed. Secondly, while walking, yes, you spoke about supported walking, but we also would be interested to know whether he is able to climb stairs, come down stairs. Does he need to hold on to a railing while climbing
patient
stairs?
Needs to hold on to railing while climbing. Actually, requires mother's support while walking upstairs and climbing down. He is also not using any walking aids as reported by the mother. Secondly,
is he able to walk on uneven terrain, and how much distance he can walk? So these are all points that you will need to cover. Okay, go ahead.
He has, parent says that the patient is able to walk for a long distance.
You can go ahead now. I mean, come to the next point.
What he is asking is basically the GMFCS.
GMFCS score
So
from
if
the
you
history.
describe this, then the examiner knows that what GMFCS is falling into.
So by the history, the gross motor functional classification score comes to class 2.
This is not a score. There are two different things. There is a GMFM score, which is a much more, elaborate scoring thing, and the other thing is a scale. So what you're talking about is the scale.
Yeah. Grade 2, sir.
It is not grade. What is it called? The precise word? It is level.
Level 2.
Yeah. Level 2.
Yes.
You said he is walking with support, right? Someone has to support him.
But walking occasionally with support. It's not, and he's not having any crutches or anything over the past 7 years. He's walking.
So if you leave him alone, he is able to walk?
Yes, sir, he's able to walk.
Fine. Go ahead. We'll come to the gait analysis later. Yeah, go ahead.
So, sir, on history, the impression looks to be like a motor disorder due to a perinatal event leading to a hypoxic damage, and probably looks like a cerebral palsy case with motor involvement of the lower limb more than the upper limb. Sir, on examination, sir, patient is well nourished.
On history.
Yes, sir, on history.
Yeah, go ahead. We'll come to the remaining points on examination.
Sir, on inspection, the patient is appears to be oriented in place. He is responding to commands, and he is well built. Patient is not having any abnormal movements which can be appreciated. On examination in the supine position, lower limb tone appears to be increased with and there is a the forefoot there is a forefoot adduction and supination with a heel varus which can be seen on inspection. There is no exaggerated lumbar lordosis which can be made out. No flexion deformity at the hip joint. On further examination, the lower limb reflexes appear to be exaggerated. There is no clonus which is present. Knee jerk is exaggerated. Plantars are upgoing. Secondly, there is no for testing power appears to be 3 in the hip, knee, and ankle. Examination of the muscles for contractures, examination of muscles for any spasticity. There is abduction is not restricted. Abduction is not restricted in both flexion and extension of knee. There is no the ankle is the foot is ankle is plantar. There's plantar flexion at the ankle which is not correctable. There is
No, this is not the way you would describe a child with CP. See, in CP, it is always desirable that before coming to this local examination, you do a gait analysis. I know, in the previous cases, we gave you an option that you can present the gait later. But I think in CP, it is, much more important that you describe the gait first and then come to the local examination. So let's do one thing. You must have analyzed the gait. So let's first see him walk, and then you describe the gait, and then go ahead with the other things. Yeah.
So, sir, as we can see, there is no heel strike which is present. Patient is walking weight bearing only on his forefoot, and there is no. He is able to walk without support, and there is he has to. There is a frequent history of falling.
So what will you describe this gait as? So there are special gaits, you have.
So it is
jump
not a
gait.
typical scissoring gait because there is no problem in clearing the foot, foot which is ahead. And there is no excessive, there is flexion at the knee while he is walking. So probably a crouch gait can be said.
Crouch.
No, crouch.
What is the position of the ankle? It's in
Ankle is
equinus or
plantar.
dorsiflexion?
In crouch gait, it's dorsiflexion.
So
There's plantar flexion. So a forefoot gait without any heel strike and a heel varus while he's walking.
So when you talk about the gait, I think there are 2 or 3 main things that you have to talk about. First is, you have to confirm the ambulatory status, which you have already, elicited on the history. But then you have to come to the ambulatory status. Second, you have to talk about the gait analysis. Now, gait analysis, again, is, from the frontal plane and from the sagittal plane. So in the sagittal plane, you have to see as to what are the movements of the ankle, the knee, and the hip. And depending on that, you classify the gait pattern. Okay, so there can be either a true equinus gait pattern where the ankle is in equinus, but the knee is in extension and the hip is in extension in the mid-stance phase. Then there can be the jump gait pattern where the ankle is in equinus and the knee is in flexion. Okay, then there can be the apparent equinus gait pattern where the ankle is in neutral, that is, the ankle is not in equinus. However, because the knee is in flexion, the initial contact is on the toes and not on the heel, and therefore you get a feeling of, equinus. Are you following me?
Yes.
Have you read this paper? It's a very classical article by Rhoda and Graham, that classification of gait patterns in cerebral palsy, in diplegia. And finally, there is the crouch gait. So this child is not crouch gait.
And neither.
What is crouch gait? What happens at the ankle?
So there's dorsiflexion, ankle dorsiflexion, knee flexion, and hip is also in flexion, sir.
Ankle is dorsiflexion,
Dorsiflex.
right?
Yes.
The knee is in flexion and the hip is in
is on
flexion.
flexion.
And finally, what
And
is the
there's
fifth gait pattern? So fifth is mixed, where both the limbs can be different. So that is that fifth gait pattern. So you have to talk about these two things, the ambulatory status and the gait. The next thing that you have to talk about, so the gait is, that's on the sagittal plane. Then on the frontal plane, you have to talk about, what is happening to the foot progression angle. The foot, is it pointing inward? Is it in-toeing? Is it
In-toeing gait
out-toeing?
is that, sir.
Then how is the patella facing? Is the patella facing forward? Is the patella facing inward? So that gives you a rough idea about the torsional profile of the lower limb. So your gait should always be from the frontal view as well as the side view. Okay? So having done that, then you come to the local examination.
Okay, sir. So there is.
I can see that Alric is already noting down all the points. And I must tell you that there is a very beautiful paper written up by him in the IJO, which I think is a must read on clinical examination in CP. Yeah, you go ahead with the local examination, and then I think I will ask Alric to take over and finish the point.
There is in-toeing is seen as patient is walk. In-toeing gait is, we can see the toes, there's in-toeing is visible, sir.
Yeah, so rather than just describing the in-toeing, talk about what is the foot progression angle.
Okay.
What is the foot progression angle? You have to quantitate your in-toeing. What do you mean by the foot progression angle, by the way?
So the angle made when the foot is just touching, when it strikes the ground, sir, after the
So
swing
it's the
phase.
angle made by the foot with respect to the line of progression of the body, right? So that is the foot progression angle. So he has an in-toeing, you are saying?
Yes, sir. There is
Of how many degrees?
So around 40 degrees, sir.
Okay, fine. What about the patella? What is happening at the patella?
So the patella is facing forward. There's no external rotation.
So you are saying the patella is facing forward, but the feet are turning inward. What does that indicate? Where is that in-toeing coming
torsion.
from?
There's a excessive tibial torsion, internal tibial
Tibia.
torsion.
So if the patella is facing forward, then indeed it is the tibia. Right. Now coming to the local examination, you have an option of describing from top to bottom or from bottom down. So what do you want to do?
Oh, sir, bottom up, sir.
Pardon?
From lower limb to upper limb, sir.
Yeah.
Bottom up, sir.
So at the ankle, what will you look for?
So the ankle is in plantar flexion. There's a plantar flexion. So
You have to quantify everything. What do you mean by plantar flexion? It is an
30
equinus.
There's an equinus deformity of 30 degrees at bilateral ankle, and which is not correctable. It's not been able to brought to the neutral
Which
position.
test have you done? See, in CP, you have one thing which is a neurological examination, and the second thing is a musculoskeletal examination, where each joint you have special tests to see for the deformities, and whether it's a fixed deformity or is it a component of spasticity. So that you have to make out by doing what is R1, R2.
R1
And this equinus, whether it's a fixed equinus, whether it is contributed by gastrocnemius, soleus, for that there are certain tests
Yes,
for
ma'am.
all the.
Yes.
So what is the test? What test have you done?
Ma'am, it was not possible to make the ankle to bring to neutral position. Secondly,
The knee flexion, is it getting corrected?
no,
with the
on knee flexion it's not getting corrected, indicating that the gastrocnemius and Sivelodowski's
Silverskjold.
test. So that means that both gastrocnemius and soleus both are affected. Ma'am, then the Q angle was measured on both sides, which indicates about the hamstring tightness. So on the right side, it's around 70 degrees.
Q angle is the angle of the knee valgus, what you measure.
Popliteal angle is measured. So that is popliteal angle is 70 degrees on right side, left side it is 45 degrees. There is no flexion deformity at the hip, no excessive lumbar lordosis which is visible. The upper limb tone is normal. There is no deficit. The fingers have assumed a position of flexion at the MCP joint.
Fingers? No.
There's a flexion.
One minute. Have you finished? Okay, at the feet, what you have to look for is the angle of equinus. Now, here again, there are two angles that you have to calculate, right? You have to calculate an angle. You have to give a fast stretch and see at what angle there is a catch.
Yes, but
what is that called?
So the R1 is the one which is the fast.
Yeah, R1. So you calculate the R1,
spasticity.
then you calculate the R2.
R2 is the slow stretch.
You
Sir.
see the Silverskjold test,
Yes,
right?
sir. Yes, sir.
So that is.
Soja.
So I think Sandeep, you can show about even the modified popliteal angle, again at the hip level,
Right.
This
So,
is the first,
combined hip
and then
abduction and Thomas tests.
so at the ankle, you initially have to examine with your knees held in extension.
Extension.
And here again, you can see that there is a virus. So whatever you have to do, you have to correct as much of the virus as possible or the inversion as possible. And you give a fast stretch. So you feel a catch at a certain angle, which is about 30 degrees. After that, give a sustained stretch. So you can see that your R2 is much better than R1. You get the first catch at 30, but then you are able to get the R2 to almost around 0 degrees, right? So R1 is 30 degrees, R2 is 0 degrees. So there is a significant spasticity. It's still not a contracture. Then you flex the knee, right? And you see how much further you are able to go. So you can get a further dorsiflexion up to about 10 to 20 degrees, right? So it is predominantly a gastrocnemius contracture with the first catch at R1, R2, R3. Due to lack of time, I won't go to the other limb. But here, additionally, you have to note that there is a tendency to go into inversion. Which indicates that the child may be having a spasticity of the tiband as well. Now, how much it is contributing to the gait, that we will have to again assess the inversion of the foot while the child is walking, because then that will determine our treatment strategy as to whether we are going to, correct the inversion as well, right? So that was about the foot. You can additionally, in cases of crouch gait, many times you have a plano valgus and you have a midfoot break, which has to be noted. So that's about the foot that you have to look at. In the knee, there are two things that you have to see. One thing is the popliteal angle. Now, popliteal angle, again, you have to look at R1 and you have to look at R2, the same technique. So you initially attach the fast stretch, see whether you get the first catch. And what is the popliteal angle? It is the angle between the vertical and this, right? So this is R1. After that, you apply a sustained stretch and see how much of further correction you're getting. So, despite this child being pretty old, what is the age you said?
9 years.
You can see that there is a significant, spasticity component over here, and the child is still not into contracture. Now, while doing so, it is very important that the other limb is held in extension. So, this is the popliteal angle that is calculated. But apart from that, there is another angle that you calculate that is known as the true popliteal angle. So what do you mean by true popliteal angle? Any idea? Right. So in true popliteal angle, what you have to do is the other limb with this knee held in flexion, the other limb you have to flex till such degree that you get a complete obliteration of the lumbar lordosis, right? And then you check for your popliteal angle. So that is called the true popliteal angle, okay? And this is the difference between the popliteal angle on this and the difference between the popliteal angle on this is known as the popliteal shift or the hamstring shift. Okay, this again has a significant bearing on your treatment decision making, as we'll come to this later. Another third angle that you have to measure is the functional popliteal angle. So the functional popliteal angle is measured with the hip flexed to around 30 degrees, 30 to 40 degrees, and then you see how much of the knee you are able to extend. Why the functional popliteal angle is important? Because during gait, hardly ever our hip flexes to beyond 30-40 degrees. So this is the real true angle of knee extension that the child should be able to reach in true gait. And therefore, this is the functional popliteal angle. Now, apart from this, there is around the knee, now you have checked for the hamstrings. The other thing that you have to look for the rectus. But to look for the rectus spasticity, so that will have to be done in the prone position, so that you can do at a later stage. Before that, you go to the hips. Now, hips, again, there are two main things that you have to look for. You have to look at the adductor and you have to look at the flexors. So first, you look at the flexors and you flex the hip till such degree that your lumbar lordosis is obliterated, and you try to extend the opposite hip. So on the left side, you can see that you can extend it fully. So the Thomas angle, Thomas test is negative, there is no FFD. The same thing you do for this, you have to flex it. So that's for the hip flexors. Then you come to the adductor. And how do you check the adductor?
Sir, first and full knee extension.
Yes. Right? So here, even with the hips and knees in full extension, you can see that you are getting a good combined hip abduction angle, or CHA as it is called. However, sometimes you may get, a restriction of abduction. Now here the problem is a restriction of abduction does not necessarily indicate that your adductors are tight, because a restriction of abduction can also occur if your gracilis, which is a hamstring, it is tight. So how do you differentiate between the two?
Sir, the flexing of knee joint will relax the gracilis, so and then we'll get to know the true.
In that case, you get the child to the edge of the table, you flex the knee, and you. Yeah. What is this test called? Read up. Okay, so fine. So it is the Phelps test. Okay. Yes. So this is about the hip that you have come to, right? So you have come with the gait, you have come with the contracture, spasticity. You already did by the Tardieu scale, and also you have to do with the Ashworth scale. For each muscle, you have to mention what is the spasticity with reference to the Ashworth grade, right? Then you come to the torsional profile. So in the torsional profile, one thing you have already mentioned that there is a foot varus. Additionally, you will come to the tibial torsion that is there. Okay, what is the angle of tibial torsion? And you will come to the angle of femoral version. So in the tibial torsion, you have to again place the child in a prone position, which will come to later. In the hip, the femoral version is measured by what is known as the trochanter prominence angle test. So here what you do is, you rotate the hip internally till such time that the trochanter becomes maximally prominent, and that gives you an idea of the femoral version, right? So here you can see that almost, I have to rotate it almost 40-45 degrees in order to get the trochanter completely prominent, which indicates that there is an excess femoral version of almost about 45 degrees. Same thing you do on the other side.
Sir, femoral version can also be tested in the prone position with the knee flexion.
Yes, that is another method. So turn around.
And sir,
another way of measuring femoral version is to calculate the angle of femoral rotations.
Sir, what was the functional angle that you said? Popliteal angle was a difference between this and this flexion, right?
One. Yes. So for the tibial torsion, you have to measure the what is known as the thigh foot angle, and that is after correction of the foot deformity, right? So you have to measure the angle between the line bisecting the heel and the line along the thigh. The same thing on this side. So that gives you an idea about the femoral torsion. And then in the prone, the other test that you have to do is the Duncan-Ellis test. So you flex the hips and you see whether the gluteal region is getting elevated. There is a mild elevation over here, but okay.
Left side more than right side.
Yeah. Okay. So as you can see, there is an elevation over here, which indicates that there is
a rectus femoris spasticity.
But then during gait, you have to see whether you really need to activate. And additionally, the femoral version, what you have to do is you have to calculate the angle of femoral rotations. So here you can see again that the femoral internal rotation is almost around 80 degrees, whereas external rotation only around 30 degrees, 30 to 40 degrees. This should be measured with a goniometer, by the way. This is just a crude method of visual analysis I'm telling you. But this indicates that there is an excess femoral version. So we have covered the ambulatory status, the gait analysis, we have covered the contractures, then the spasticity grade, then the torsional profile. The other thing that you have to look for is what is known as the
a lag or some quadriceps lag, which will not.
Yeah, so that is the motor power that we will come to. Motor power is something that you have to measure. Though in the presence of excess spasticity, it may be difficult to assess the motor power. The last two things that you have to measure is the selective motor control. That is the child able to control,
isolate a movement, there's a flexor response.
So for that, what you do is you ask the child to dorsiflex the ankle, and you see whether he is able to. Better,
Sida.
So to see whether the child has a good selective motor control, what you do is, बेटा ये पंजा ऊपर करो, मेरी उंगली को टच करो, उंगली को टच करो मेरा, ये पैर से अपने पंजे से अपने मेरी उंगली को टच करो, करो. So mass response. See, you know, when he tries to dorsiflex the ankle, there is a movement of the knee extension as well as hip flexion. So he has a very poor selective motor control. So that is there. And finally, you have to look at the core strength. How do you assess the core strength? Core strength means the proximal truncal control and what strength the child has in the proximal body. How do you look for that.
Head lift.
No.
Yes.
So
Okay.
for that, you make the child kneel, stand in the kneeling position, and see whether he is able to maintain that kneeling position for at least about 30 seconds to 1 minute. चलो अभी खड़े हो जाओ, घुटने के ऊपर खड़े हो जाओ. हाँ. So see, he is able to get up to a kneeling position on his own. Indicates he has a pretty decent core strength and proximal muscle control. Okay, and so he is able to maintain that for 30 seconds to 1 minute.
Sir, this W sign that I was sitting like that, does that have any significance?
That indicates that there is an excess femoral version, which you have already
excessive
measured on the
okay,
torsional
okay, sir.
profile. Alric, could you add the finishing touches? No, let's ask him the diagnosis. Yeah. Diagnosis.
So 9-year-old child who's come with complaints of inability to walk and frequent falls, who has an in-toeing gait, with a fixed deformity, with a plantar flexed ankle, correctable, is most likely to be suffering from with spasticity of the gastrocnemius, and excessive femoral version is probably suffering from and upper limb completely normal, suffering probably from spastic diplegic cerebral type of palsy, cerebral palsy.
A few things are there. I think you presented quite well. You know, a case of cerebral palsy is not an easy thing to come in the exam. I think when we were giving our exams, it was optional to have a case of CP, and we knew that if we get a CP case, we were going to fail. But if it comes in your exam, you have to be sure that this is going to be quite common now. You know, so I don't think you can avoid a case of CP. In fact, I would say if it comes in your exam, you'll be lucky, because even if you say a few things like how you have said, I would definitely say that you have done quite well. Yeah. So what are the important things that we should, how to examine, you know, a child with CP? I think Sandeep has shown that beautifully well. Few things in your diagnosis: avoid terms like suffering from. We never use those words because no one suffers from anything. Okay, all of us are suffering from lots of things otherwise. So we just say this is a child with. Okay, so one, you never say this is a spastic child, you never say this is a CP child, there's never a diagnosis. This is a child with cerebral palsy, so that you are respectful to the child and the diagnosis. Okay. So you should begin by saying that this is a case of cerebral palsy. Rather than saying all your positive findings first, when you ask for a diagnosis, your diagnosis says that this is a case of spastic cerebral palsy. Most likely spastic diplegia. So when you give a diagnosis, you first give your anatomical diagnosis, your functional diagnosis, sorry, which is spastic cerebral palsy. Then you say what is the motor type, which is spasticity. You say what is the topography, which means which part of the body is affected. So is it diplegia, hemiplegia, monoplegia, or a quadriplegia? Okay. And then you talk about the functional limitation. So that's how you should present your case. So never present a case. So when you begin a diagnosis for a hip, for example, you say this is a case of Perthes, and then present the findings in that. All right. So how many of you all are able to sort of present the way this gentleman presented? Are all of you all confident with presenting a cerebral palsy case like how he did? Because I think if you present it this way, I think it's fairly good. Yeah. The important thing to understand in CP is that unlike other conditions, you don't focus on one joint at a time, because you'll never finish your case then. Okay, unlike other cases where you say a full detailed hip examination, you cannot do that in a case of CP. So you have to have a broad overview the way Dr. Sandeep has shown you. All right. So I'll just give you a few important points that you should say, because I'm sure if you say that, and you know, any of us, your examiners, will be happy with your level of presentation. So as Sandeep rightly pointed out, you begin with a history, but not too detailed, because otherwise what happens, you land up with so much of detailed history that it takes up the bulk of your time. You want to come to a diagnosis and management quickly. So what are the points on history that you're looking for? Definitely a birth history very quickly. So was it preterm, at-term, post-term? Was it a cesarean section or was it a normal delivery? Something about the postnatal period. So was the child in the NICU for some time, because that's a high-risk patient then? Did the child cry soon after birth? If you know the ABCA score, there's something about the ABCA score. So very briefly about the birth history and the perinatal period. Okay, so that's the first thing. Second is any risk factors in the mother. So if you know that mothers were hypothyroid or epileptic, then these are risk factors for the child. So a little bit about that. Quickly go on to the developmental milestones. So you don't have to give a full detailed history. When you say child was in NICU, then you don't say, you know, child was 4 days, then he was given this, then he underwent some IV treatment, then he was given phototherapy. It's not required. Very quickly, NICU stay for 4 or 5 days, and that's it. So you don't have to go to the intricacies of everything, otherwise you'll never finish your case. Next is your developmental milestones. Quickly, we are interested, there are a lot of milestones in children, but we are, as orthopedic surgeons, interested in motor milestones. So neurologists will present a case of cerebral palsy very different from the way we present. We are interested in motor function because that's what we can do. That's what we can impact.
Sir, should we like during these milestones also mention that whether he has any cognition disability or
Yes, of
that should be
course.
left out?
No, there are a lot of
Considering that we are
things.
not going to be handling that at our level.
Exactly.
Should we be
so you
leaving
can make
that
a
out
brief mention. So that's what I said. A neurologist who's presenting will talk of cognitive issues, communicative issues, behavioral issues, because that is their forte. Our forte is motor function. So we'll very briefly talk about those. So that means, you should know the definition of CP. So if I ask you what's the definition of cerebral palsy, then you know what you should examine for. So how do you define cerebral palsy?
Sir, it is a permanent problem of the posture and movement of a person due to
Very good. So let's go step by step. So it's a permanent disorder. So first of all, it's a group of permanent disorders. So cerebral palsy is not a diagnosis. It's not like Perthes. It's a group of disorders because there are 100 things which can cause cerebral palsy. So it's a group of permanent disorders
of posture and movement.
of the development of movement and posture. So movement and posture is critical to the diagnosis of CP. So of the development of movement and posture,
Due to us one single
accompanied by
insult to the
activity limitation.
accompanied by activity
That's
limit
extremely important.
due to a single insult to the immature developing brain.
Occurring due to a non-progressive,
Non-progressive
injury to
non-progressive
the developing fetal or
or
infant brain. Okay? Then? So that's the motor part of it. These motor disorders are
which may be accompanied with cognition and sensory impairment.
very good. So these motor disorders are frequently accompanied by disorders of sensation, perception, cognition, communication, and behavior, with epilepsy and musculoskeletal problems. If you say this is a full definition. This tells you what you need to examine in a child with CP. All right? So I think that's an excellent description that you are given. So it's a group of permanent disorders of the development of movement and posture, accompanied by activity limitation that occurs due to a
non-progressive single insult to the immature.
Does not be single. That's not necessary that it's single. I don't think that even the definition that word single comes in. So this is a definition by Rosenbaum, which has been recently approved in 2007. So accompanied by, that's caused by a non-progressive lesion to the developing infant and fetal brain. Before we used to say up to 2 years, up to 3 years. We no longer use the 2 or 3 years now. We just say infant and fetal brain. Okay? And these motor disorders
which
are accompanied by
with sensory impairment, cognitive disability, difficulty
perception,
in perception,
communication, behavior, epilepsy, and musculoskeletal disorder. So this tells you what all you need to examine. What is the ching for? We are done with this case? Yeah? Okay, good. So I think what you have described is perfectly good. All right? So you begin with this history taking. Then when you come to examination, as Sandeep said, those of you who are interested, look up an article which is there in Journal of Indian Orthopedics, which came out last year. It has given you a detailed view of how to examine. So don't go step by step. All right? The first thing we look at when you see a child with CP is always the gait. Okay? So unlike other cases, as Sandeep rightly said, in other cases you may keep gait at the end. In CP, gait comes in the beginning because what we can impact is the gait abnormality. So describe the gait in detail the way, you have already said it. If you can classify the type of gait, it is very good. So Sandeep has already spoken to you about the different types of classification. So whether it's diplegic, hemiplegic, these simple classifications, at least you should know if it's a diplegic, you have these 4 types, which Dr. Sandeep already told you about. True equinus, jump, apparent equinus, crouch. All right?
Sir, for this patient, if you could just tell us the gait pattern, like I couldn't.
So
In-toeing was made out and absence of heel stance can be made out.
So describe it qualitatively. Whatever you're seeing is not even important if you can't define it. But if you can qualify what you're saying, so this child, first of all, is he walking with support or without support? So that is the GMFCS levels. Okay? So he's walking on his toes. So that's simple. So he's walking on his toes with hip and knee flexion, all right, with in-toeing. So that itself tells you that this is a jump gait. So if you just describe it this much, it's more than sufficient. Okay? You don't have to go into much of details.
Sir, difference between a jump and a true equinus, I didn't get that. Sir.
True equinus is only if the child is on his toes.
Okay, sir.
If the child has hip and knee flexion along with it, that's jump. So I didn't see very clearly. If he has only on his toes,